Hello, I'm Lisa, a pediatric physiotherapist for babies and toddlers. I've seen firsthand how small, everyday habits in modern parenting can lead to big issues for our babies. In this podcast, I'm going to show you how to prevent those issues, treat them if necessary, and restore the joy to parenting. Hello, and welcome back to the Best for Baby podcast. I'm your host, Lisa Rogers-Sargent, and today we're finishing off our little mini-series on hypermobility. Now, the first week was all about little babies, pre-walkers. The second week was about how hypermobility can affect children's ability to start walking and in fact affect the way they walk as well. And today we're going to look at a slightly older age group. But if you haven't listened to the previous two episodes, please do go back and listen to those, as this is just a follow-on from those. So I'm going to continue where I left off rather than recap the previous two. Now, why I think it's important, even though this podcast is very much about babies, is that it's all the advice that I give parents when I go and treat their little ones. And I prepare them for what may be part of their child's future as their child gets a little older. Now, that doesn't mean that all children with hypermobility will go on to have any of the symptoms I'm going to describe in today's episode, but they are very, very common, particularly with little children who have needed physiotherapy at some stage to address their hypermobility. And that's why I never finish seeing a patient without giving the parents the heads up for all of these things, because once you are forewarned, of course, it's much easier to address, and also it just gives them a bit more incentive to work really hard at the activities I've prescribed, because we do see children whose parents really tackle doing the activities with them and in fact create active little children who have worked hard and developed quite good core stability. They are less likely to develop these symptoms because they have been addressed. A lot of these symptoms will be children who have always been hypermobile but have either had physiotherapy for it but not really followed through and done the full course or really worked hard at addressing it, or they're the little ones who've always been hypermobile but were never seen by physio. So let's dive right in where we left off with last week's episode. We're talking about children today who have been walking for quite some time. Usually I'm called to see these little children between the ages of 3 to 5 years old, because that's when these symptoms become most obvious. And it's usually because they are either now in formal nursery, or some of them in this country at age 5 have started school. And although schooling at this age and nursery is very much free play, the children move around, they sit on the carpets, it's not so much stationary sitting at a desk, it certainly does become evident that their ability to do so, to sit still at a desk or to sit still on the carpet or to move around their school environment, is very much affected. And it's also the age where they are with educational professionals who are used to working with many, many children in this age group, and so they can spot any difficulties really quickly. So it's quite a lot of children that we see in this age group being referred for physiotherapy due to their hypermobility symptoms. So in the last episode, where we looked at delayed walking, walking on the toes, or walking with really rolled in feet, I talked a lot about children tripping and falling as a result of their foot posture and their reduced awareness of their feet. And this is one of the classic signs that gets the child referred to physiotherapy in this age range, because by about 3 years old, we expect the child's gait pattern, their way of walking, to have matured significantly enough that they're not tripping and falling so much anymore. They should be quite stable, quite comfortable on their feet. A lot of them running well, running upstairs, even with one foot, then the other foot going upstairs, running downstairs, jumping off a step. And so by this stage, they've developed a lot of really good skills on their feet, and we would expect them not to be tripping so much when they're walking. So if they are still at this age, they usually do get referred for physiotherapy, and very often we find it's because of the hypermobility for the reasons I mentioned before, which was their foot position, that wobbly ankle that's not holding their foot in a great position, their reduced awareness of their foot, so they're not placing it in the best position to keep them stable while they're walking, and also their reduced spatial awareness, so tripping over obstacles, walking into obstacles. And so that's what's causing the trips in this age group. So that's usually something that has been noticed by the parents, and it's the parents who are referring the child either to the doctor and then coming to physio, or bringing them straight to physio. Another thing that we find parents seeking help for is the foot position, so the little flat foot. Now, I described that in the previous episode because it's very common in that age range, so under 2, the foot rolling in, the flattened arch of the foot, that's very common. That's a typical little baby foot. But when we're hitting ages 4 and 5, perhaps even 6, we're expecting to see a more adult foot. We're expecting to see a good medial arch, and if we don't, it's very clear that there's some significant hypermobility in that ankle joint. And if that's the case, the flat foot itself is not a concern, but it's a sign that we've got significant enough hypermobility that I'm expecting to see some other difficulties going on. Very often parents will refer their children for the flat foot because they think it looks strange, or they're worried that it's going to damage the foot, or they can't understand why the child's foot looks like this. And we just have to say, well, it may change slightly over time. The likelihood is that at this age, if we are still seeing that persistent flat foot, we'll expect a certain degree of that in adulthood. And that is not something to necessarily be concerned about. It's not something that means that the child will need insoles on an ongoing basis. In this case, I tend to, if they're just concerned about the way the foot looks, or the fact that perhaps they're tripping and falling, I'm unlikely to recommend insoles at this stage, because I really want to build the awareness of that foot and strengthen that foot. So I don't tend to put them in insoles for that reason at all. And I always reassure parents, because we know, if any of you are runners, long distance runners, when you go to buy running shoes and they do an assessment of you, they look at the way you run, because there's many types of shoes, and we have running shoes for people who pronate, and for those who have a neutral strike, and those who supinate, and these are just the ways that the ankle rolls in. And very often the hypermobile ankle is that inward rolling ankle, which is something that later on in adult life, if it's persisting, if it's not significant with a really flattened foot, it's just that inward roll of the ankle, it's purely just what we call pronation or overpronation. And there's a whole set of running shoes for that, because it's just very normal. It's just a certain percentage of the population, their feet do that. Maybe some of them were hypermobile children who had slightly flattened arches, that with strengthening and aging and tightening up, it has improved to the point where they just might need a different kind of running shoe. And actually, I read a study that said people who are the overpronators tend to actually run a little bit, I can't remember, I'm going to get it wrong, but it was something about they run really fast, or they faster than supinators, or something like that. But it was a good outcome. And for me, it just shows that, even at this age group, if we've still got a slightly flattened foot, it doesn't necessarily mean anything we need to be concerned about. However, we address it. We work hard at strengthening and sensory input through that little foot to make sure it's ready to give it the best chance, so that it can go on to be something that doesn't affect them any further. Now, another thing parents will notice, as opposed to the school teachers noticing, is that the child complains of pain in their legs. It's very often in the knee joint, but it can also be in the ankle joint, in the foot itself, or even in the thigh, in the muscles. And usually this pain comes on at night. So just before bed, the child really starts to complain of a lot of pain. Sometimes they can't describe the pain very clearly. Sometimes it's very vague. I always say to parents, ask your child to put their finger on where it hurts. And if it's a big area, to put their hand on where it hurts, so they can show you. But usually it's kind of not very well localized. It's spread throughout the leg. It comes and it goes. But the one sort of constant pattern is that it's usually there towards the nighttime. And the reason that this happens in this age group is because suddenly the demand of the child to be walking on their feet is much higher. So now they are at nursery, or they are at school, and they are on their feet a lot more during the day. They're not being pushed by mum during the day in their pushchair. They're not spending as long as in the high chair. They're not being, sitting in front of the telly. Maybe some parents do, or maybe some parents will sit and play with their children, whatever it is, or sit and read with their child. Whatever it is, we find that they are on their feet a lot more from this age, at the school going or nursery going age. Also, they've got peers running around. Particularly, in this country, we're really, really good about having outdoor playing schemes. So during the nursery day or the preschool, certainly in the early years, they have the children outside playing for a large percentage of the day. And I think it's because we don't have sunlight in the evening. So they try and use those school hours to get the children out having some fresh air. And what we find is that little children are racing around after each other. They've got a lot of play equipment outside, pushing things, scooting bikes and things like that that schools often have. And suddenly they are far more active and running about on their feet all day. And if we look at the hypermobile ankle, which rolls inwards, it's going to put some strain on the inside of those joints, as well as the little knees will follow that trajectory, and very often the knees roll inwards. Now you might see it might look like a knock knee, what we used to call knock knees, but you might not even be able to notice it. But it's following the trajectory of the foot. The foot is rolling in, so we're having a lot of strain being placed on the inside of the knee. Those inner ligaments are being hammered, the bone is being pushed hard against each other, and so we get a lot of stress and strain on the inside of the knees and the ankles. You might also find some children, the hypermobility is not inwards, it's actually in the knees but backwards, so they can straighten the knees beyond what other children can. Almost so the back of the leg forms like a bendy banana shape, and that puts a lot of strain also on the knee joint. And it's after a day of being out, putting pressure on the joints, and at the end of the day it's all kind of cumulative, and they're fatigued and they're tired, and that pain is just triggered. And it can be excruciating. It can wake them up in the night. It can be really, really intense. And the treatment for this is obviously to manage the symptoms, first of all. And I'm not a doctor, so I'm not going to tell you what drugs you would use, but that's something that you would, if it's really severe, you would discuss with your doctor and know, giving them whatever is the appropriate medication to control their pain at night is number one. That's your first thing. Don't underestimate it, because it can be very, very severe. Secondly, if it's being caused by that inward rolling of the foot, this is when I would issue a child with insoles. Sometimes, if the foot is not very classic, typical hypermobile inward rolling, we would refer them on to a podiatrist who would make a mold of the foot and make a custom-made insole for them, so it fits only their foot. However, I do think if it's that classic inward rolling, we can do a lot of good with an off-the-shelf insole, and then with that, we give them a really structured physiotherapy program of strengthening. And the strengthening now is your muscles are in the thigh and a little bit in the calf, because we're trying to support the knee joint particularly, because that's usually where the pain is coming from. Some children, it's more focused in the ankle and the foot, and then we will give more structured activities and exercises to strengthen there. These children are a little bit older, so you can, if they're kind of 5, 6, you can get them to do repetitions of activities. Otherwise, it's still very much play-based, but it's quite targeted strengthening as opposed to building movement, educating movement, building stability, building sensory awareness and improving sensory processing. Here, it's very much repetitive strengthening, like you or I would do if we went to the gym to get nice and strong. And we support, if the joint is able to do, like for example, that knee that can do the banana shape, we don't stop them going into that position. It's almost impossible not to do that. We strengthen them in that range so that they have better stability around the joint and are less likely to have pain. So it's a multi-structured approach. You do need pain relief in terms of medication, insoles if necessary, and strengthening. And very often, it's again, because they are repetitive exercises, it's something I can teach parents, and parents just do them over and over again, and you do it in short bursts. Short bursts, make it a little bit fun, have a reward chart if you need to, but it needs to be done over and over again, and that's how we see the best outcomes. Now, another thing the hypermobile children in this age group get referred for is delayed gross motor development. And again, this is maybe something that the school teachers may have remarked on, but it's usually again the parents who have noticed, and it'll be things like hopping or balancing on one leg or playing certain ball sports, or even now parents are starting to take them to age appropriate groups and clubs like gymnastics and ballet and mini football and things like that, and parents are starting to compare this child to other children, and they can note that there's certain things this child can't do that all the other children are doing in that age range. It might also be things like they just can't get them to ride a bicycle, or they can't use a scooter. And it's not that they haven't had enough chance to practice, it's literally their little bodies are not able to do these things. And again, this is very much to do with the body awareness, the joint awareness, the proprioception. It's to do with that spatial awareness, because they've got to understand how to use the ball, to catch the ball, to ride the bike, to jump. You need spatial awareness for that. It can also be the power component, because their muscles have to work so much harder. There's more difficulty in doing these things. But very often with hypermobility, we also find, because their development has happened slightly differently along the way, and because their sensory processing is also different, their coordination is very much affected. And so these higher function, more tricky activities are very difficult for the child to get right very quickly. And sometimes we need to address all those things. We need to build up their overall strength, stamina, stability, as well as working on the sensory side of things to build up their proprioception. And that then translates into better coordination. And then we can see, with some treatment and with some activities that are done specifically to address coordination, we can see an improvement, and the children then kind of catch up and carry on with really good outcomes. However, sometimes children are referred at this stage for those difficulties, and parents are noticing things like they trip and they fall a lot. They're really clumsy. They call them clumsy. They can't do these gross motor skills I've been describing. And they've either been incorrectly diagnosed, or they're kind of in the process of being diagnosed with something called developmental coordination disorder, DCD. So these are children, you may have heard people talk about them, they have a coordination difficulty, or apraxia, or dyspraxia. People throw these words around really easily. And the thing about those difficulties and those disorders is that they can only be diagnosed in the absence of anything else that may be causing that clumsiness or that slight delay in the gross motor ability. So with these children, if they're hypermobile, that means they can't have that DCD. They can't have dyspraxia, which is difficulty in planning movements. They can't have that as their primary diagnosis, because they're actually hypermobile. And if we treat them as hypermobile children, so like everything I'm describing, then we find that poor coordination, that clumsiness, that poor motor planning is very well addressed. There might, with some children, still be a slight element that persists into adulthood, but it's nothing that has a major impact on their life. Whereas children who really have dyspraxia and coordination difficulties, that's not something that strengthening them, helping their sensory processing is going to massively improve their presentation. What they need is different activities which really work on counting and practicing and planning movement and working on components of movement and doing them with rhythm and method to help them plan. And you almost do it for them as many times as possible before you slowly give them less assistance, and so their body learns to kind of take on the coordination. But it's with every task almost you need to teach them and train them, as opposed to the hypermobile child who at this stage has achieved most of their gross motor skills, and now what we're trying to do is just strengthen them up, and then we should see them going off and being able to learn gross motor skills on their own. So those are two quite different fields, but often easily confused. So a really big one that we don't talk enough about in hypermobility is fatigue. Now these little children, their muscles have to work so hard, first of all, just to keep them up against gravity. So in sitting like this with a chair rest behind my back, my head is, I've still got to hold my head up. I've still got to do, there's no side rest. It's not very supportive, this chair. So there's still a certain amount of muscle activity required to keep me up against gravity just sitting in this chair. Little children in the school-going age, they're not being pushed around in buggies usually. So they are walking, they are running, they're scooting, they're riding on balance bikes. Some of them in this age group may be riding bicycles. During the day, they're on their feet a lot. They then sit on the ground, on the carpet mostly. There's not so much sitting on chairs and tables. On the ground, there's almost no support. So the hypermobile child might flop into their W sitting, which we see a lot of here, because that doesn't require as much core stability or control anywhere. They just really flop deep into their hip joints. Or they get uncomfortable. They start to fidget because their muscles have to work so hard to hold them up on the carpet. And towards the end of the day, once they've been doing all of these things, they are exhausted. And their muscles have worked so hard to keep them up throughout the day that they are absolutely broken. Now, remember, I keep saying sometimes not only are their ligaments affected, so their joints are very hypermobile, but their muscles are also not hypermobile, but they have stretchier connective tissue supporting the muscles and interweaving through the muscle fibers. And as a result, the muscles too have the effects of being hypermobile. And so they really have a double whammy up against them. They're having to work so hard to do anything that it's exhausting for them. So what we see is the start of the day, maybe we're all fine, and then as the day wears on, if they have to sit and be still, they cannot. That is more exhausting than moving. So they start to fidget and they change their position, or they lean on the wall, or they lean on their hand, or they start to kick or move around because they desperately need to change position because it's exhausting to be static in one position. Very often these are the children who, when they go for long walks with the family, they will ask to be carried. They will ask to get back in the buggy, or the parent will always say, oh, they hate walking. They always want to be in the buggy, or they want me to carry them. Or they will complain of sore legs as well, or they will complain of their legs being tired. They will be the child who prefers to sit than to stand. They will always be like leaning against furniture, leaning against the wall, leaning against their mother. And you can just see it's because their little muscles are constantly working so hard, they are exhausted. And wherever there's opportunity to switch those muscles off, they will. Or if they have to be static for a long time, to change position, they will. So that fatigue really affects family life. Very often if a family sits down around a table to eat dinner, this is the fidgety child, or this is the child as well. Already they're having problems with eating because of their fine motor control, which we'll talk about in a second. So they're messy, they're slow to eat, plus they start to fidget, they move around all the time. When they go out as a family, they want to be in the buggy. They're just tired, they're always not wanting to go on family trips, things like that, because their bodies are shattered. And in the school situation where they have to sit on the carpet or later on sit in chairs, these are the fidgety children, and very often incorrectly diagnosed or earmarked, perhaps they have ADHD. However, they could have ADHD as well, and then there's a problem with their attention. But if this is pure hypermobility, these children, if they are well supported and they don't have to work so hard to sit, they can focus beautifully. And it's a real shame because these are the children who need tiny amounts of support. It's not even hard. They just need the correct chair to sit on, or lean against a wall, or get up and have movement breaks. So very often I write a letter to school and I say to the teachers, please can you allow this child to be the child who gets up and hands out the books, or goes and collects the milk for the day, or goes and collects the fruit, or is the star helper with this. Anytime you can, please give them an opportunity to be the child that moves without it being overly noticeable to the others. Sometimes we also give a stretchy TheraBand that we tie between the chair legs, and so they can push their feet into it. And that pushing is a sensory stimulation, so it calms them and enables them to feel a little bit less like they need to move. But also if their feet just can't reach the ground, it's something for their feet to lean on, and they can relax, they can switch off some of their muscles. Sometimes we give them a roll to put behind their backs, or we ask teachers to make sure they have more opportunity to sit against furniture, against a wall if they're on the carpet. So there's lots of little easy strategies to help. And if this child is truly hypermobile with good attention, these little things should really help, and you will see a massive difference. However, obviously, if they have other things going on, these little things aren't going to completely solve the problem. And along with those few little adjustments we can make in the classroom, again, we want to strengthen them, we want to improve their stamina, because it's not just about being able to sit still and focus, it's about being able to walk with the family to the park and not get tired and exhausted, or whatever other activities that are normal for a child of that age. And we need to increase their exercise tolerance, their stamina, their strength, their stability, again through the age appropriate exercises. So I've mentioned briefly about the fine motor difficulties, and I've spoken before about how being hypermobile can have a knock-on effect on your fine motor control, because you can have hypermobile joints in your fingers and your intrinsic hand muscles can also be affected. And this is usually where the teachers start to notice things in this age group, and therefore the child gets the referral on. Sometimes they end up getting referred to occupational therapists because they are the fine motor specialists. However, they might end up with a physiotherapy referral. And this usually is because they are having difficulties with their pen grip. So it's an immature pen grip, and we know most children by 6 or 7 years will be holding a pen correctly in what we call a tripod grip, which is how most people write. A lot of 5, 6-year-olds won't have that. They might still be holding it in a fist, but usually 6, sometimes 7, the children have got that adult pencil grip, and anything over 6 or 7-year-olds that are still using a fist to grip are delayed but likely to catch up. Now, the hypermobile child who beyond 6 years old, 5, 6 years old, is still holding a pen like that, we might see that persist into adulthood because that becomes habit. And so we really need to work hard at strengthening these muscles inside the hand, and we want to help them to get really nice and strong and practice, give them lots of opportunity to hold the pen correctly so that that habit doesn't kick in, so that later when they have the strength in their hands to hold it correctly, it's now a habit and they continue to hold it in that way. So as physiotherapists, we are not the fine motor specialists, but we can help promote strengthening, and there are lots of different activities. I mean, you can just look on YouTube, there'll be millions of ways you can do it, but playing with Play-Doh, crumpling up balls of paper, pulling apart Lego, pulling apart Duplo. I often give parents a sticky Velcro, and I get them to stick it to different toys of different sizes, and they have to pull it apart in different grips. And then, of course, picking up beans, throwing them into packets, pulling on stretchy elastic bands, playing with blue tack, anything like that that will strengthen the little hands. We also know that they might have difficulty, using scissors, in which case we just say to parents, give them lots of different things, draw pictures, get them to cut them out, then get them to cut cardboard that's a bit thicker and harder. And so those are nice exercises to strengthen those intrinsic hand muscles. And along with practicing to hold the pen correctly, there's a variety of different pencil grips that you can buy that really just make a pencil fatter and therefore easier to hold in a correct grip. Now, you could also take some stretchy like elastoplast and wrap it around a pen or a pencil and get the child to use that pencil every time, or buy fat crayons or chalks or things to get them to practice with. And so it's a combination of strengthening and also preventing habit being formed there. Then we also have to look at something that I've spoken about so much, which is the sensory side of things. So parents, if a child hasn't, been seen by a physio or an OT by this stage, very often they will think there's an issue going on with the child's behavior, or that the child is very shy, or that they're wild, or that they're very cautious, or they're always running and bashing into things, they're loud, they, crazy, and bouncing off walls. Or it's the opposite, they're just totally afraid of movement and avoid movement. And that's, as I've explained in the previous episodes, to do with their sensory profile, which can be one of two ways because of being hypermobility. So you can't predict how it's going to affect the child, but very often these little issues that parents are worried about can come back to the hypermobility. And again, we find with proprioceptive, sensory, strengthening and stability exercises that tends to improve, but a lot of that can also be habit based. So certain behaviors become habits, so we need to work on that side of things as well. And then finally, something that parents notice, teachers notice, that fits very much with fatigue is the child's posture. So the child very often in a classroom is always slouched or slumped over a desk, and that's because the muscles are tired and they are finding their ways to not have to use their muscles so hard to stay upright. And perhaps the teacher's always saying, sit up straight, please sit up straight, please sit up straight. Some of the schools are quite on it, and they give the children little wedges to sit on or little air cushions, which helps them, because they know the posture in itself is not a problem. The fact is that they probably need a little bit more activity happening in the core and in the back muscles, and that's what those little devices help with. Otherwise, it's parents who find that the child is always slouched and slumped over, and it annoys the parent or it worries the parent. And so they seek physiotherapy. And again, this is something that requires that intensive, regular exercises, repetition of the same things, which is why we can always teach parents. It doesn't mean you need to keep coming to physiotherapy. We can teach you things because it's that repetition of those activities and those exercises that will bring about the greatest improvements in the child's posture and stability. So those are all things I warn parents about. And the things that I really want you to remember would be, if there's pain, it's easily treatable, but first don't blow it off. Believe your child and make sure you're treating it appropriately as advised by your doctor. And secondly, they just need a little bit of physiotherapy to get nice and strong, and then you can probably let them go on their way. If it's really severe and coming from the foot position, they can have a foot sole for it, but the idea is we want to get them back out of foot soles later. The other big one that I warn the parents about is that people are going to think your child has ADHD, they're fidgety, they can't sit still, they have poor posture, they are wild, they are running about, they are badly behaved, and this might not be the case. Of course, I have to say though, I think true bad behavior in a little person is not really a thing. I think children react to how they are treated and also to what their bodies are telling them to do. So I don't think children are innately bad in this age group or badly behaved in this age group. So there might be other things like attention difficulties perhaps, or sensory processing difficulties, or even autism that looks very similar. So it's always worth getting a little bit of help, but knowing that it could just be hypermobility, in which case we just need to get them nice and strong and active. And then of course the big one is fatigue. Don't ever underestimate how exhausting it can be for hypermobile children to get through the day and to just do what we take for granted that our bodies can do with ease. So those are the big ones. And then there's the pencil grip, the fine motor difficulties that we sometimes see that get flagged. And I warn parents about that and all the other things I've just said, because I want them to say, yes, my child is hypermobile, so let's just see if we can give them a bit more support and address that and see if it changes, because schools are quite concerned sometimes and they don't always know that hypermobility can mimic these other areas. So sometimes parents are really worried and devastated, and they know that their little one had physiotherapy, a couple of years ago, but they don't realize that it could be connected. And so then when school comes to them and says to them, your child has a problem with concentration, or we have these concerns about your child, the parents don't realize that it could just be the follow-on from hypermobility, and it's time for a bit more physiotherapy or occupational therapy, or just a few little activities. And so I always warn them, because it can be a big shock being told something like this by your child's school, when very often it's really something that's quite easy to deal with. So if you have a little one, please just bear these things in mind. You don't have to remember all of this, but just remember, when your school does challenge certain things about your child, it might just be worth getting a referral to a physiotherapist so that they can assess and tell you, actually, this is what we need to do, or yes, let's get a further referral. So that concludes our mini-series on hypermobility in children. I would very much like to do another episode on how hypermobility persists into adulthood and perhaps young teenagers. And I'm not sure when that will be. Unfortunately, I can't conclude the series with it because I'm not an expert in that, but I've got a very expert, amazing physiotherapist who's a very dear friend of mine that I'm going to get to come and tell us about that and how it can affect our children as they get a little bit older, and perhaps we might even identify some things in ourselves. So that will come at some stage in the future. So please do look out for that. And after this episode, I will be on holiday, so you won't hear from me for a couple of weeks. So I wish you all a good Easter break. And I just want to let you know, finally, my next episode is going to be an interview with an osteopath. Now, she is very, very experienced at working with babies, although she does treat adults as well. But we'll be talking about what she does with babies, because she is fantastic. First of all, she's an incredible osteopath. But also because a lot of people ask me, what is osteopathy and will it help my baby? And I do certainly refer children onto osteopaths, and if they're anywhere near her geographically, I refer them onto her because she's brilliant. So please do join us. You will absolutely fall in love with wonderful Stephanie James from Osteoperformance in Wimbledon. So if you're needing an osteopath before that episode comes out in about 2 or 3 weeks, then please do go and look her up. But otherwise, I look forward to you joining me for that conversation after the Easter break. So with that, I'm wishing you all the very best and all the best for your baby.